So I'm going to talk about when to start antiretroviral therapy after diagnosis. Now, I'm not going to talk about CD4 thresholds. That's all finished. We know that everybody with whatever CD4, and I'm not going to go into all the sort of variances about tuberculosis and cryptococcal meningitis, etc., because that's all done. I'm really going to talk about your day-to-day practice and when to start antiretroviral therapy after diagnosis. So why are we pushing to start people as soon as we can? So in other words, you have a diagnosis, then we say, please start treatment. Well, we've got high genetic barrier drugs now, and that's important when it comes to things like resistance. And there's a problem that when you've diagnosed someone with HIV, there's a long time sometimes before they get the laboratory results back and you've given them therapy, and what happens is they don't come back. And in lower middle income countries, for example, in the project we run in Tanzania, you diagnose someone in the countryside and you give them a piece of paper to attend a clinic. And we have problems getting them to the clinic because they go, I'm positive, I'll go another day. Okay, so that's another issue. And often clinics set up a whole process. Oh, we have to get you prepared to start treatment, so it can take a long time. You have to come to multiple visits. So, and delays in treatment are associated with increased mortality, morbidity, and the CD4 count, if it keeps going down, it's harder to recover. And of course, there's the whole transmission issue. And I'm going to focus on that a bit later on in the talk. And obviously, in acute HIV infection, which is rare to diagnose, frankly, if you start early, you can decrease the reservoir. Right, so there are some questions you have to ask yourself about when do you start the treatment. So who would benefit most from giving treatment there and then? I've made the diagnosis, I'm going to give you the pills now. Is it the people you suspect are difficult to keep in care? Well, what physicians believe are difficult patients and what patients believe are often very different. What about people who come in very late stage with CD4s, they're well, but their CD4's 200 to 350. And what about patients you've diagnosed in clinics that aren't attached to hospitals, for example? That's what I'm talking about, lower middle income countries where you might be doing community testing, you might be doing self-testing, etc. And the other questions really is, if you do start earlier, will you make the transmission less? So do the effects happen? And are you going to affect the patient's reservoir by starting as early as possible? The main thing that we also need to know is what are the long-term benefits of starting people as soon as you find them. And then finally, for you guys, and I'm going to cover this now, is what about the implementation? Is it best to do it in a hospital, medical centers, family clinics, private clinics? Where is the best place to do it? Now I'm going to start my talk actually with a definition confusion. So you hear rapid, same day, and immediate. What about rapid? How rapid is rapid? Is it within 72 hours, 48 hours? Is it there and then, within a few hours, on the same day? And then they say, let's compare rapid, which I don't know what that is yet, okay, because I don't know what the definition is. Nobody sat down and told me, versus they then call it delayed. Now, I don't like delayed, because that sounds like I'm not really thinking about it, and it's pejorative. Maybe it's better to call rapid or considered. But maybe a lot of rapid is considered. So we need to get some terminology so we can all get this right. Why am I fixed on this? Because when you look at the studies, what people call rapid, same day, immediate, are all very different. So here's some the guidelines from the DHSS. Treat the infection rapidly. They don't say what rapidly is, and effectively to achieve sustained viral suppression. So is rapidly within 4 hours? Is it within a day? Is it within 3 days? A week? Most of us, it's within a couple of weeks of meeting the patient, right? So, but is that rapid? Maybe it's not to these people. So, what about immediate? Is immediate the same day as a diagnosis? Now, that's really important. So you diagnose somebody, and on the same day you give them pills. That is one study you could do. But the problem is, often they call it, what happens is that doesn't happen, right? Because they get diagnosed, then they come to the clinic, maybe 3 days later. And then people call same day, the same day as the clinic contact. when did you get your HIV diagnosis? A year ago, you could say. But when did you come to the clinic? Today for the first time ever, because I decided to. Oh, I'm going to start you on same-day therapy. Okay, so that is the problem with a lot of the definitions we've got. So same day as diagnosis, you could call that rapid. Same day as clinic contact, you could call that rapid. But there's a gap between, often, diagnosis and clinic contact. So immediate start, I would say everyone starts on the same day as HIV diagnosis. That's HIV diagnosis, not clinic contact, that's HIV diagnosis. Now that could be essential in acute HIV infection. Someone comes in with late pregnancy and very late presenters, and we've got a trial in Europe looking at that. But what about the routine asymptomatic patients that you're diagnosing with all sorts of viral loads, CD4s and everything? What are you going to do with them? So most of us do this. We consider the start. We say everyone's going to start as soon as possible after we've diagnosed HIV, but we want to get some time for reflection, some time for discussion. And really, what we're saying as physicians is, I'd like to know their results before I give them any treatment, please. I want to know their resistance, I want to know their viral load, I want to know their CD4, et cetera, right? So we sort of run parallel tracks. In our head, we're going, what are the results? But for the patient, we're going, we better get them ready for this when we're starting. So what do the guidelines say? When they've seen all this mess of definition, they still don't help us in defining things. So DHSS, they say the long-term benefits aren't proven in the US, because remember, these are US guidelines, but it could potentially improve the clinic outcome, and it's resource intensive. WHO say recommended where feasible. Well, that's different in the Congo, South Sudan to South Africa, right? So that's IAS USA or EACS start ART as soon as possible, including immediately after diagnosis, if the patient is ready. Who's making that judgment? Only the patient can make that judgment, right? So that's interesting. But I'll show you some data from low and middle income countries which shows that if you do start antiretroviral therapy immediately, you do reduce the loss to time of follow-up and decrease viral suppression. So what we've got to ask ourselves, will immediate start be better than what we do now? Okay, will it be better than what we do now? That is the question, that's the scientific question to ask. Otherwise, we're going to get messed up, and we need to know what all these definitions are. So, Nathan Ford from WHO has looked at, I think that's the pointer, yeah, has looked at 4 randomized controlled trials. Same day, this is ART, that's not same day as diagnosis, that's same day as contact, right? Was associated with better retention in care, viral suppression, and decreased likelihood of loss to follow-up and death. So that looks great, but the problem is all of these trials are from low and middle income countries, where you would expect that if you can get people there and capture them, right, and start them on treatment, you would see a big impact. What about in high income settings? So here's the lower middle income setting from one of the studies from Thailand. Those in the same day ART program were nearly 4 times more likely to start the therapy. I mean, you know, that's incredible, but that's obvious because you're there saying, here are the pills, whereas the other people you're saying, could you come back? And they may not come back. And in there, those in the same day ART program were 2.2 times more likely to be viral suppressed. Well, overall, that must be true because they're taking the pills from day one. But anyway. And here's some other data from Lesotho. Again, same day versus usual care in terms of engagement in care. It's better engagement in care, and the viral suppression was better. But I would just want to point this out. 50% versus 34% viral suppression, right? So that same day ART has increased it, but it's still not where you want it to go. So what about high income settings? This is from one of our clinics. And basically, we now get to definitions, right? So this was before they started same day therapy, and this is after. First of all, note the small number of patients, and time to the first doctor appointment, right, still was up to 12 days. Characteristic, a time to ART initiation was still between 3 and 20 days. And this was trying to get people to do same day ART. So, you see what I mean about the definitions. Then you can look at this, US clinics. Here's the US clinics, here's the San Francisco data, again a small number of people. Time from diagnosis to ART initiation, 7 days. first clinic visit to ART initiation, they got it straight away. So you can see here, a lot of these patients were diagnosed before they got to the clinic. But when they got to the clinic, they were given therapy, okay? And mean linkage to care in this, in New Orleans, 1.3 days, and the REACH program in Atlanta, again, 7 days from diagnosis to ART. So these aren't all 000s. And here's some of San Francisco's data from 2013 to 2016. Diagnosis to care, that's care, first care visit to ART. So now they're starting pretty rapidly, okay. So it's interesting that people are doing this, but the numbers are relatively small. And here's some data from New Orleans, where again the numbers are small, that link to care 100% whether you started immediately or you did within 72 hours. So this is basically the same day or within 72 hours, but you can see retaining care was better same day than within 72 hours. People weren't coming back even when it was a 3-day appointment. So Mark Boyd has looked at all this evidence, and his statement was, in high-income settings, that's what HIC stands for, with the lack of robust evidence, there's no standard framework. And part of that is all around the fact that we don't have enough people in studies, in trials, we don't have a good definition, we really got to know what we're trying to do with all of this. So what about clinical trial data? Well, there is a trial going on. It's Diamond, although I put the, I've updated this, but never mind. They put the 48-week data in, which is very, very similar to this. There's very little difference now. I'm sorry about this. I thought I'd updated the slide, but it's really very, very similar. They had discontinuations in 10 patients, and basically, though, it's a single-arm study. So it's really just non-randomized phase 3 trial of rapid initiation. And basically it's saying that you get a good viral suppression rate in this group. But, and they had 29% of patients enrolled within 48 hours. So that's still not great, is it, in terms of rapid start? So what about the community? What do patients think? You always have to think about this, because we might be going down paths going, let's start and let's do this. Well, a lot of patients are worried when they get diagnosed HIV, and many go, I want to get treated right away, and I just want to start. So that's, if they're stressed, that's important. They also see treatment with a sense of hope that they're going to have a normal lifespan. And of course, there's this undetectable, right? Meaning it's untransmittable. So that worries the risk to partners. And the main reason that we had it in our clinic was that people said, I want to start straight away, please. You've just diagnosed HIV, can I have the pills? But of course, that's not everybody in the world. Dean Street Clinic is very much white, Caucasian, gay males between the ages of sort of 25 and 40. And well-informed patients have high levels of interest, so they know about therapy. So, and it really then, why I'm bringing this to the forefront about the patients, remember this has got to be patient-centered care. It can't be, we must do this because we have to do this, because we believe in it. We also have to engage the patients in this and make sure that they do too, if we believe that that's the right thing to do. So what about the same day as diagnosis? I just put this couple of case examples up. So someone comes in and they get diagnosed in front of you, and you say, I want you to start straight away. And then you look and you see that they've got severe mental health issues. Their viral load is 1,000, yeah? So what argument do you have with them about starting therapy? Or they're homeless. Just a few examples, right? They've got no place, and you're going to say, take these pills and come back in 2 weeks. Okay, so I don't know whether that's a good thing to do or a bad thing to do. I have no idea, because we don't, actually. So it really is important about which groups is it going to be good for all? Is this going to be a disaster, or is it going to be a revelation for us? So there are other concerns. Getting people to the clinic once they're diagnosed. So whether that's home testing or whether that's they're diagnosed in the countryside, they have to come to a center. I put transport because in lower middle income countries, if you go to Africa, transport is one of the biggest barriers to accessing therapy. The readiness to start. Now, they get influenced by doctors, so even though they're not ready to start, you can convince them they should be, and that may not be a good psychological thing to do. How long it's going to take you to counsel the patients? And what about your clinic capacity? So what I'm saying then is every clinic has to be ready for any patient that's diagnosed at any time to be able to go There's somebody available to talk to the patient, somebody available to prescribe the drugs, somebody able to talk to them about therapy, get their next appointment going, et cetera, and get their bloods taken and review all the results, right? So if you've got a very busy clinic with lots of new diagnoses, you have to be really geared up for that, rather than say, we've diagnosed you, we're going to take your bloods, we'll see you in a week, and we're going to arrange everything from there, okay? So that's interesting. We have no idea about long-term outcomes yet in high-income countries. The availability of regimens. Imagine you've only got efavirenz. Well, in Thailand, they give that straight away, okay? But most of us would feel a bit nervous if we just had NNRTIs as first line for these patients. Resistance testing, is that important? I'll come to that later. What about in lower middle income countries where you've got to screen for tuberculosis and cryptococcus, because you don't want to start giving people antiretroviral therapy like that while they've got active OIs going on. And the cost. Okay, so that's a few. So in low middle income countries like South Africa, what they do, they screen patients here, you can see, for TB. So if you've got a TB symptom, you are not included. And the same for in Kenya, most of these people are screened for TB. If you have a persistent headache, they don't start you. If you've had any antiretrovirals before, they don't restart you. If you're not ready, okay, et cetera, et cetera. So the trouble with tuberculosis symptoms are, have you got weight loss? Yeah, I've got HIV. Have you got fevers and sweats? Yeah, I've got HIV and I've got something else. So it can be a bit difficult to exclude all these people. Okay, so what about patient information? Well, you know, you've got to do this. If you're going to see them and start them straight away, you've got to go all through this, discuss antiretroviral, talk about life expectancy, support and empower, or you've got to have someone in the clinic to do it for you. And they've got to be there in every clinic on every day because you don't know when these patients are going to turn up. But what you don't need is the results of these tests that we all do. Now, what about saying, I need to start the patient today because then the risk that they will transmit to their partners will decrease, okay? And then within a few weeks, they'll be undetectable. Well, that's absolutely true. However, it is also true that most patients who you could give any therapy to, you could say to them, we found you're HIV positive. Until we know that you're undetectable, you need to use protection or not have sex, right? Use protection. So, but this is some interesting data from the UK. It looks a bit complicated. Number of casual sex partners in the 12 weeks before and after the diagnosis. Now, this is primary HIV infection. So these are people with very high viral loads. And obviously, they picked these people up and wanted to know what happens. Well, this is interesting because those people who had 1 to 5 numbers of casual sex partners when they had the infection, if you look over time, right, and they were started on treatment, their number of partners went down to basically 0 over 12 weeks, okay? But these people who had high numbers of partners, right, the guys that have loads of partners, they didn't seem to change their sexual behavior much. And that's more about the psychology of them than it is about them worrying about health, yeah? And it's interesting that. But most people, if you tell them, they will change the way that they think about their So if we're going to adopt this, I'm trying to convince you, let's do it. Let's get it all organized and get the clinic sorted out and everything's going to be great. What therapy is best? Is everyone going to start on a boosted PI? Well, we don't know. We're doing a trial at the moment in late presenters of a boosted PI versus an integrase. But should everyone just go on an integrase? Plus one other drug, because we've got data on 2 drugs, 2 other drugs, or should we give them 3 drugs in case their viral load's 10 million and we don't know because they've just turned up? I don't know what to do. I mean, it's interesting. So what about resistance? And Dan mentioned this data. In high-income countries, does resistance matter? If you're going to start them on dolutegravir or bictegravir or a boosted PI even at the beginning, right? So the conclusion was with INSTI-based first-line regimens in the US, minimal clinical benefit to do any of it, right? So you might as well just start them. In fact, you're going to get your results back, hopefully, in high-income countries within a week or 2 weeks, and it's unlikely you're going to develop significant resistance to the drugs you've given just for that short period of time, although it's possible. What about in low-income countries? Well, I don't know. There's increasing rates of drug resistance. These are NNRTI, but there's also NRTI-resistant mutations. But there is intriguing data from both Thailand and from KwaZulu-Natal that even with extensive resistance to nucleosides, if you give a triplet, a efavirenz Truvada, they're still doing well. So it's very interesting that whether or not resistance is an issue. So what do the guidelines say? Well, EACS, ISUSA say, if you're going to do immediate, right, use a high genetic barrier drug. And that is a boosted PI, dolutegravir or bictegravir. The DHSS say darunavir or dolutegravir, but they even tell you which nukes to give, tenofovir and tricytopine. Okay, so there you go. That's what the guidelines say. So, in conclusion, I don't know what the right definitions are, but we need to get our act together to say what we mean by rapid, immediate, same day. Because same day as diagnosis, same day as clinic visit, etc. We really need to get that if we're going to do any studies in this, and to make them consistent. The next thing is that it looks like you get better linkage to care, and it looks like it's well tolerated. I haven't shown that data and safe. But in high-income countries, if we're going to do this, we need some sort of framework to be able to do it with. Immediate ART leads to earlier viral suppression, and an increase in retention and the sustained viral recession, but we do need long-term outcomes. It's no good just looking at 6 months or a year. And we can implement it in many clinical settings, but which is the best one? And we really need to get organized if we're going to do this. And we need to study it, because the studies in high-income countries especially are not good enough. And we need a team. We need a team, and we need to empower the patients, and also we need to convince our providers who are funding us that this is worth the extra cost that it's going to do. So with that, I'd like to thank you all for listening.